Hello, good afternoon, everyone, and welcome to session P22, Risk Factors and Prevention. My name is Diaz. I'm Project Officer at Alzheimer Europe, and it's a great pleasure to be here today sharing this session with you. One of our speakers, Anna Odin, will not be able to join us today, so we are going to have our four speakers, and then we will leave the final time for questions and answers. Please, you have a chat function. Make sure you leave your questions and suggestions for our speakers. And without further ado, I would like to introduce our first speaker, is Leonie Visser. She's a postdoctoral researcher. She's currently working at the Center for Alzheimer Research at Karolinska Institute in Sweden. She's also affiliated to Amsterdam University Medical Center in the Netherlands. Her research focuses on physician-patient communication in the context of Alzheimer's disease and the memory clinic setting, with a special attention to the perspective of people with Alzheimer's disease or other forms of dementia and their care partners. In this session, Leonie will present data from her previous postdoc project at Alzheimer Center Amsterdam in the Netherlands. Leonie, welcome. The floor is yours.
Thank you. Good day to you all, and thank you, Anna, for the introduction. My name is Leonie Visser, and today I will present to you about the reasons of patients and their accompanying care partners for visiting a memory clinic. And these are results of the ABIDE project, which stands for Alzheimer's Biomarkers in Daily Practice. These are the disclosures of Alzheimer Center Amsterdam and me. I'm a postdoctoral researcher, and my research focuses on medical communication, mainly in the field of Alzheimer's disease and dementia, and care provided in the memory clinic context. And currently I am employed at the Center for Alzheimer Research at Karolinska Institute in Sweden, but I previously worked at Alzheimer Center Amsterdam and the Department of Medical Psychology at Amsterdam University Medical Centers in the Netherlands. And I'm also still affiliated to Amsterdam UMC, working together with over 30 consortium partners on the Dutch ABORT projects. As said, my work focuses on medical communication in memory clinics, but why is this so important? Well, increasing numbers of individuals seek care at the memory clinic in early disease stages. And because of advances in biomarker testing for Alzheimer's disease, these tests are more often used and may warrant disclosure of test results to patients and their care partners. And this also means that physicians and patients must communicate about dementia risk and other uncertainties that come with biomarker testing. And it comprises a lot of information and much complex information. In addition, to prevent disease progression and/or crisis later in the disease trajectory, it is essential to engage individuals in the management of their disease and health care, and communication is important for that too. But what do those individuals actually want and expect? What are the reasons of patients and their loved ones to seek care at the memory clinic? And what do they expect or hope to achieve by visiting the memory clinic? To answer these questions, we conducted an observational study in 8 Dutch memory clinics within the context of the ABIDE project. Based on this study, we previously already published several articles reporting results. But today, I would like to focus on the questions I previously mentioned. What are reasons of patients and their accompanying care partners for visiting the memory clinic or seeking care at the memory clinic? What do they want to achieve? We involved 115 new patients who completed a survey when first visiting the memory clinic. And those patients were on average 71 years old. They were approximately half of them were female, and they had an average mini-mental state examination score of 26. In addition to the survey, we audio recorded their consultation with the physician. And from 105 of these patients, audio tapes were available for analysis. And 93 of these patients were accompanied by a care partner. We used qualitative content analysis to code or categorize first the patient's answers to one open-ended question in the survey. And this question was, what was your objective or goal for visiting the clinic? And in addition, we categorized the audio recorded communication. So we coded expressed reasons for visiting the memory clinic, or the motives to go to the memory clinic, or patients and care partners' reasons to seek care as they voiced it in the consultation with their physician. And 2 independent raters coded all answers to the question and the communication, followed by a consensus meeting. And we then used descriptive statistics to report on frequencies and percentages. And here are the results from the open-ended survey question. Most patients, 61%, reported that they wanted to find a cause for their symptoms. Half of those patients said that in these specific wording, and the other half stated more in general, that they wanted to get clarity or certainty. But also remarkably, 19% of patients reported other reasons than stated in this table. So other reasons than confirming or excluding dementia, finding a cause of symptoms, or confirming or excluding another diagnosis. Those other reasons were related to treatment. For example, I want to know if we can do something about my memory problems. Reasons could also be related to arranging care, such as this person who said, to enable me taking part in daycare activities 2 or 3 half days a week. Patients also reported that they wanted information, for example, to collect as much information as possible about dementia, or about the risk of developing dementia in the future. And various other reasons were also reported, and some even reported not to have a reason themselves. For example, this person who said, I did not have a goal. For me, this consultation wasn't necessary. This table then presents which reasons were expressed or voiced in the consultation with the clinician. And as you can see, about half of patients and more than half of care partners did not express what they wanted to achieve at the memory clinic. And when combining these numbers, we realized that for 43% of patients, no reason at all was voiced. So neither the patient nor the care partner expressed a reason to seek care. And here as well, you can see that 18% of patients reported other reasons than already mentioned in this table. A variety of other specific motives were expressed, from I want to know if I have a genetic predisposition to I want to get tested so I could drive a car again. And we also noticed that some patients asked the doctor for advice on how to deal with or manage with their symptoms or disease. For example, this person who said, I want to know if maybe there are any possibilities to structure things more or remember things better, or any aids or strategies to train myself maybe, or to change my eating habits. In this table, we then compared the reasons reported in the survey with the observations from the audio recordings. And each row represents a reason as reported in the survey. So for example, in the second row, you can see that 66 patients reported in the survey that they wanted to find a cause for symptoms. And in the columns, you see how often this reason was then expressed in the consultation. From these 66 patients, 39 did not voice any reason, 12 expressed the same reason, and 15 stated a different reason in the consultation with the physician. And based on these comparisons, we observed 2 things. First, patients who reported that they wanted to find a cause for their symptoms seem to be less likely to state this to their physician. Second, we noticed that about a quarter of patients, 23%, expressed a different reason in the consultation with their physician than what they had stated or reported in our survey. So, what are our conclusions? A considerable number of patients reported reasons for seeking care that are not as obvious and often quite specific. Over half of patients and accompanying care partners do not express their reasons for seeking care in the first consultations at the clinic. In 43% of consultations, no reason at all was expressed. The reason that is voiced in the consultations does not necessarily correspond to the reason that is reported in the survey, indicating that patients' reasons for seeking care or the goals that they want to achieve at the clinic can be really complex and multifaceted. What can we learn from this, or what can we do with these results? Well, first, it's important to tailor care to the individual, from decisions about diagnostic testing to the provision of relevant information and management of expectations. And to allow such tailoring to the individual, the diagnostic trajectory should start with a conversation about patients' and care partners' reasonings for visiting the clinic. And a simple question by clinicians, for example, what do you hope or expect to achieve here at the clinic, could be a simple starting point. We should also try to stimulate patients and care partners to express their needs and wishes more often. In the Abide project, we have developed tools to support the communication between clinicians, patients, and care partners, which you can find on www.adapt.health. For patients and care partners, this includes a list of example questions to ask the physicians and some educational animated videos that can help them prepare for the consultation with the physician. And if you are interested, please visit the website or contact me, shoot me an email. I would like to end this presentation by thanking all partners and participating clinicians, patients, and accompanying care partners for their efforts, and by thanking you all for your attention.
Thanks so much, Leonie, for a very interesting and very clear presentation. We will have you later for the questions. I'd like now to introduce our third speaker, just to remind the audience that unfortunately Anna Odin, who was the third speaker, is not here with us today. So the next speaker is Kathrin Steichele from Germany. Kathrin holds a master's degree in movement and sport gerontology from the German Sport University in Cologne. Currently, she's working within the project DigiDem, a digital dementia registry in Bavaria. And DigiDem Bayern is a project that examines the quality of life and care situation of people with dementia and their family caregivers in Bavaria. In this context, she addressed the question whether exercise programs have an impact on dementia-related symptoms in people with dementia. Kathrin, welcome. The floor is yours.
Thank you, Anna, for your kind introduction, and thank you for the opportunity to talk about my systematic review on the effects of exercise programs on cognition, activities of daily living, and neuropsychiatric symptoms in people with dementia. I wanted to talk about non-pharmacological treatments and exercise in special. So exercise has been recommended as an effective treatment to slow down cognitive decline, to improve activities of daily living, and to reduce neuropsychiatric symptoms, shortened with BPSD over here. And even though exercise has been recommended, many trials reporting conflicting results, and thus evidence for its effectiveness seems limited. So what we aim to get is an overview of the state of research in this field over the last 5 years, and this is exactly what we did with our systematic review. So we wanted to address exactly this question, whether people with dementia have a benefit of exercise programs for their cognition, for their activities of daily living, and for BPSD. And we figured out that one possible reason for inconsistent results between trials may occur because of different inclusion criteria. For instance, the lack of a formal diagnosis, or to mix people with dementia with people with MCI. So we included only trials with community-dwelling people with dementia who had a formal diagnosis. And furthermore, we only included randomized control trials. Any combination of balance, strength, or endurance training was included as far as the isolated effects of exercise could be measured. And that means that multi-domain interventions, such as combinations of exercise with cognitive training or extra gaming, for example, need to be excluded. And as a control group, we accepted usual care or social activities. So we searched in 8 databases, and this resulted in over 7,000 records. And after screening, the remaining 99 records were assessed for eligibility. and thus 7 trials could be included in this reviews. Reasons for not being included were the lack of a formal diagnosis, as I was saying before, or the inclusion of people with MCI, or maybe the combination with other interventions like exergaming or social participation. Now I just want to give you a short overview of the important study characteristics. And total sample size ranged from 27 to 415 participants, which is quite a big range. And as you can see here, especially baseline cognitive function measured with the MMSE varied between studies. For those of you who do not know the MMSE, this is a screening tool measuring global cognition. And also mean age varied between 70 and 84 years, sorry. Most of the trials had a duration of 12 to 16 weeks, but one intervention lasted over 52 weeks, so it's a year. And mostly they conducted aerobic training, multimodal training, or strength training. And to give you an idea of what a multimodal training intervention could include, it was mostly the case if participants started with a warm-up, followed by exercise for coordination. Maybe they had some strengthening exercise after that, and then ended with aerobic training, for instance, walking or cycling. Now, to get back on the studies, I shortly want to talk about the study quality, which varied greatly between the studies, with 3 trials raising some concerns and the others raised high concerns. And this mainly occurred because of incompleteness of outcome data, selective reporting, or insufficient blinding of outcomes assessors of participants. As you can see here, 6 of the included studies measured cognition, predominantly global cognition, and training modalities such as frequency or intensity did not differ greatly, with most of the participants trained 2 to 3 times per week on a moderate to high level of intensity. Concerning the setting, most of the trials were conducted in supervised groups of 3 to 10 people, whereas 2 studies analyzed individually guided training sessions. Interestingly, one study, Oehmann et al., compared the same intervention in 2 different settings. One group performed exercise in a supervised group, while the other intervention group trained at home with the same intervention. And as you can see here, none of the trials demonstrated a significant superiority on global cognition of the intervention group, which performed either aerobic or multimodal training, as I was saying before. And even though I don't want to focus on that, I need to mention that there have been inconsistent results in cognitive subdomains, such as executive control, which are not listed over here. Another interesting finding was described by the largest trial we had. It's the one of LAMP, and they found that the participants in the intervention group had a greater worsening of cognition after the intervention stopped. So yeah, that was the largest trial, and it has a sample size of 415 participants, and it has had the highest methodologic quality. On this slide, you can see the 2 trials which analyzed the effects of exercise on activities of daily living, and both of them conducted a moderate to high intensity exercise training over 16 weeks, with 2 guided training sessions approximately, but type of training did differ between the 2 trials. One had aerobic training, for instance, walking or cycling, and the other did a multimodal training, which I was explaining right before. And both of them did not find improvements in ADSL. Last but not least, I want to talk about the effects of exercise on BPSD. And these were analyzed in 3 trials, with all of them used supervised training sessions, but with different training types. For instance, one trial conducted an aerobic strength training, and one created a multimodal trainings intervention. And the last of the 3 trials compared a chair-based strengthening program with chair yoga. And one study described less severe neuropsychiatric symptoms after aerobic training, but neither of the other interventions led to improvements in BPSD. First of all, I want to focus on the effects on global cognition, which are in line with the previous Cochrane review from 2015. And this is in contrast with several other publications which found improvements in cognition, or especially in global cognition. And compared to our study, these trials and reviews included people with MCI and without a formal diagnosis of dementia. And interestingly, one of the included studies compared exactly these two groups and found improvements in cognition after multimodal training intervention in people with MCI, but not in those with dementia. And thus, they concluded that physical exercise should only be recommended in the early stages of Alzheimer's disease and not when the disease progressed. And even though we cannot conclude that physical exercise has an impact on global cognition, there was one trial which found significant superiorities in executive control, which I was saying before. And this study compared a multimodal training intervention in a home-based setting with the same intervention in a group session. And this intervention only led to improvements in executive control when it was delivered individually guided in the home-based setting. So there's this possibility that individual guided training sessions are to be preferred. And as I was saying before, one trial found significant worsening after the intervention finished in the exercise group compared to the control group, and thus concluded that there might be something like a rebound effect, and therefore future studies should consider long-term follow-ups. As I was saying before, none of the included trials found improvements in activities of daily living. These findings are in contrast to a previous Cochrane review. In this review, authors concluded that findings should be interpreted with caution and rated quality of the evidence as low, since there was an unexplainable high heterogeneity with only 2 out of 6 trials found improvements in ADLs. And at that point, I want to emphasize that the largest sample size of over 400 people and the high quality of one of the included trials, which did not find impacts on activities of daily living after a multimodal training intervention. Concerning BPSD, 1 out of the 3 studies found improvements. Since the type of training varied between 3 trials, and this was the only study evaluating the effects of aerobic exercise, it seems likely that the effects of exercise depend on the type of training in this case. And this suggestion is in line with a previously published review, which found improvements in BPSD after aerobic exercise training programs. Now to get back on the target question, I want to conclude that this systematic review found that exercise cannot be recommended neither as a treatment option for a cognitive decline, nor is there evidence for the improvements in activities of daily living. What I want to tell is that there might be beneficial effects on BPSD through aerobic training, for example, walking or cycling. And due to these findings and the possibility that exercise programs might harm your cognitive function after stopping them, we should rather focus on the maintenance of an active and healthy lifestyle rather than following exercise programs. So now that I would like to invite you to ask all of your questions, and thank you for your attention.
Thank you so much for that, Kathrin. Really interesting and a lot of food for thought for later. I'd like to introduce now our last speaker, Francesca Farina from Ireland. Francesca is a postdoctoral research fellow at the Global Brain Health Institute, Trinity College Dublin in Ireland. She holds a Bachelor of Arts in Psychology and a PhD in Neuroscience from the National University of Ireland. Her current work focuses on identifying risk factors for dementia and strategies to promote lifelong brain health. In 2021, Francesca was awarded an Alzheimer Association International Research Grant to investigate fear of dementia and its relationship to midlife risk. So congratulations, Francesca, on that grant, and the floor is yours.
Thank you so much, Anna, for the introduction, and thank you to the organizers for the invitation to speak with you. I'm delighted to be here. My name is Francesca, and as mentioned, I'll be talking about my work, which looks at fear of dementia and its relationship to potentially modifiable risk factors. So I suppose why look at fear? So if you look at the literature, it shows that fear of dementia is quite common in the general public. So a survey by ADI in 2019 surveyed 70,000 people in countries all over the world and found that almost 80% of people worry about developing dementia at some stage in their lives. We also know from other studies that at least in some communities, such as people aged 55 plus in Western cultures, at least, the fear of dementia is higher than any other age-related disease, so cancer, stroke, heart disease. At the same time, we're seeing much more representation about dementia in things like the media. So many people will be familiar with this film, which came out last year, which tells the story of a man who is living with the diagnosis of dementia and his relationship with his daughter. So of course, it's great to see such representation in the media, but I think it's interesting to look at the type of language that's used when we talk about representations like this. So this is from one of the popular reviews about the film, and they describe the film as a kind of horror, if horror is also tragedy. They say it's not scary horror, but it should scare the stuffing out of anybody who has contemplated their own failing memory. That prospect is far scarier than anything Freddy Krueger ever threw at us. So obviously this kind of language is quite scare-inducing. And so I think this is where we're at in dementia research, where we're having a lot more awareness, certainly of different types of dementia, but it's maybe not translating into an understanding, a clear understanding, particularly in terms of the stages. And so what's happening is that people are familiar of dementia, but they don't necessarily understand it. And what can happen then is that can induce fear. And this is problematic because we know that experiencing prolonged fear about something and intense levels of fear can be very harmful to people. We can think of fear as a type of Yerkes-Dodson relationship, an inverted U shape, where of course fear can be a great motivator up to a certain point. So each of us has an optimal level of fear. Fear can help me discuss something with a friend that I might be worried about, or go and talk to my general practitioner. And so it's very functional. But what can happen to some people is that they get a fear overload. So when someone experiences fear over such a long period, it can have the opposite effect in that people start to withdraw, to avoid, they'd rather not deal with the situation. And this cycle of fear avoidance is what I'm interested in the work that I do. So to give you a little bit more detail about what this could look like in the context of dementia, if we think about someone who's experiencing worries or fears, someone is afraid that they might develop dementia. Maybe they've had a parent with a diagnosis. What can happen is they become very sensitive to potential signs of that disease. So they start to monitor themselves for every time they forget a name, they experience a memory lapse, they walk into a room and forgot why they went there. That kind of monitoring over time can be very fatiguing and effortful. And so what can happen is people actually experience an increase in their perceived memory failures. And as people ruminate over time and they worry, that can then bleed into behaviors. So in this case, we have someone who, because of their fears, start to lose motivation. It might start to affect their mood, and they may actually withdraw from activities. So some of the people that I've spoken to, older people in the community over in Ireland, and also people with MCI, they talk about being worried about embarrassing themselves in situations. They avoid social situations that are quite demanding, or they might avoid going to the supermarket at very busy times. And what you can see happening here is that person's world starts to become smaller and smaller. And we know that social isolation is a risk factor for dementia. And of course, all of those changes in behavior then reinforce the initial fear. So it becomes a self-perpetuating cycle that someone can get stuck in. So in my work, in the study I'm working on at the moment and have been for the past year or so, we're looking at the separation of fear and avoidance. So as I mentioned, fear can be functional, fear can be a great motivator, but what we don't want to happen is for the fear to cause people to start avoiding situations. And if you look at the literature on this, people tend to ask a single item question: how afraid are you of developing dementia? Are you afraid of developing dementia? So that question doesn't really get at the avoidance, at the functional aspect. So a couple of years ago, my colleagues and I developed a scale to measure both fear and avoidance, specific to memory loss. And we decided to focus on memory loss because we wanted to avoid the term dementia, being perfectly honest. It's quite a nebulous term. People have different definitions. As I mentioned, the understanding isn't always there. So we decided instead to focus on something people were very familiar with, the symptom of memory loss. So we developed a 23-item scale. Half of the items look at fear and half look at avoidance. So here's a couple of examples of this scale items relating to fear. So they're things like, I often worry about my memory getting worse. I'm afraid I might embarrass myself. Whereas avoidance look at things like forgetting is a sign I should place fewer demands on my memory, or I can't be as social anymore. And these results were published the scale was published in Aging and Mental Health last year. And all of this came from semi-structured interviews with older people, caregivers, and also people who work in the healthcare sector. So they informed all of these items in item development. And then we gave the questionnaire to about 300 older people living in the community. So the first, a small study with about 70 people, and then a follow-up with 230 people, an international sample, which were about 70% European. And then we looked at the association between fear and avoidance and various different psychosocial and lifestyle factors. So in the graphs here in green, what you're seeing is people's fear scores, and in orange, you're seeing avoidance scores. So here we're showing a relationship, a positive association between fear avoidance and self-reported memory failures. So as expected, the more fearful and avoidant people are, the more self-reported memory failures they're reporting. We also looked at objective memory test recall. So when we gave people a verbal memory test, we found a separation between the fear and avoidance. So here we're only showing a negative association between avoidance scores and test performance. And there's no significant association with fear here. We also looked at mood. So positive association with fear, avoidance, and depressive symptoms, and sleep disturbance. Again, a positive association here. Finally, we looked at social engagement and quality of life. So social engagement was engagement in daily activities, and quality of life was an overall measure of someone's quality of life and functioning. And we found significant negative associations here with both fear and avoidance. So these associations were promising and indicated that there was a relationship here. But we next wanted to try to control for some potential confounders in this analysis. So first of all, general anxiety. Is it the case that what we're really measuring here is a general propensity for anxiety? Are the people who have fear and avoidance fearful about everything? So we controlled for general anxiety. And then the second one was the objective memory performance. So is it the case that these relationships are very tied to whether or not a person is experiencing a measurable change in their cognitive performance? So we repeated the analysis using hierarchical regression analysis, controlling for general anxiety and objective performance in step 1, and then putting fear and avoidance into step 2. And these were all of our outcome measures in the separate analyses. And what you see for fear and avoidance is a lot of these relationships hold up. So just focusing on fear specifically, after controlling for those variables, we still see the positive associations with self-reported memory failures, depressive symptoms, and sleep disturbance. While for avoidance, we see the relationships maintained for social engagement and quality of life. And this is in line with what our model would suggest. So fears and worries are much more linked to mood and perception of self, while avoidance is much more linked to the functional aspect. We also, just to mention, looked at age. So there's been mixed literature on this, whether fear tends to go up or down as age increases, and we found no relationship between fear, avoidance, or age. We also found no differences in sex. So we see females here in yellow and males in purple, and there was no difference in either fear or avoidance scores. We did, however, find a difference with family history of dementia. So interestingly here, for people with a first-degree relative who had a diagnosis of dementia, they were more fearful than people without a family history, but they weren't more avoidant. So the fear was increased in people with a mother, father, or sibling who had a diagnosis, but they weren't avoiding situations anymore than people who didn't. And overall, what these results are showing, I think, is that there is a clear distinction between fear and avoidance patterns that we can see in community dwelling older adults. And again, this is something that hasn't really been looked at too much in the context of dementia. There is a lot of work looking at fear and avoidance of falling after someone's had a fall, or other chronic conditions like chronic pain. So I guess, why is this important? Well, I think that fear and avoidance are very treatable with standard psychotherapies. So even something like fear can be looked at with psychoeducation. And I propose that addressing fear and avoidance could potentially target multiple risk-reducing pathways for dementia, social isolation being the obvious one. And I think this is something that could be looked at quite an early stage, so maybe not just in older adults, but also in midlife. And this is exactly the future directions where I'm going with this. So we're all familiar with this Lancet report, looking at the modifiable risk factors. So I'm working with the Prevent Dementia program at the moment, to look at fear and avoidance in middle-aged adults, and with the aim of measuring this over time, and also looking at who is most vulnerable. So are there differences in people who have a family history, or who have other risk factors? And really trying to tease apart who's most vulnerable to avoiding, to not just the fear, but the maladaptive avoiding component. And then simultaneously, I'm also working with colleagues in Northwestern University in Chicago, and we're looking at how we can manage fear. So regardless of its origins, how can we break the fear cycle? And we're doing that by developing some tailored interventions, again, beginning with community-based older adults, looking at how we can address fears through psychoeducation, and also mindfulness and some behavioral activation exercises. And that work is ongoing at the moment. And finally, just to acknowledge all of my mentors and my collaborators, and also my funders, and to say thank you to all of you for listening. My details are on the screen if anyone wants to contact me, and I'm also on Twitter. Thank you.
Thank you so much, Francesca. That was absolutely great. Very, very interesting. Can I now ask all the different panelists to have their cameras on, so we can start with the questions and answers session, if that's okay for everyone? Kathrin and Esme, can you put your cameras on? Kathrin? That's wonderful. Well, hello everybody, and welcome now to the session to the questions and answers session. And while you were speaking, I think you had a fantastic presentation. We had a very lively discussion in the chat. There's loads of different questions. And I think I was also, as you were speaking, thinking hundreds of questions. So I hope we have 20 minutes. So I think we have a very large question and answer session. What I'm going to do is, as in our panel, we can see those who have been more voted. I'm going to start in the order that I can see in the panel, if that works for everyone. Would that be okay? Okay, the first question I think is for you, Leonie, and it was a question about whether when you were presenting, whether the patients and their care partners share the same expectation and goals, or whether you see any differences in goals and expectation among them.
Yeah, really good question. And indeed, we observe differences between patients and care partners in the diet, so that they had a different expectation or reason or goal. And in general, patients more often reported and voiced the other reasons, so different various specific goals or reasons for coming to the memory clinic, while relatively care partners more often expressed that they wanted to confirm or exclude dementia, or to find a cause for the symptoms. So I guess patients just on average or in general more often had a really specific type of question to the clinician, while care partners just wanted to know where the symptoms would come from. Yeah.
Thank you so much for that clarification, Leonie. I have to say, when you were presenting, I was really shocked by the amount of people who would not have said anything to the clinician in the conversation, where in the survey they did have some expectations and ideas. So that was really, really interesting. And I think the second question is also for you, Leonie. And it's about, they were asking that the Amsterdam UMC is a memory clinic in an academia/research context. The question is, are there a difference in the reasons compared to a regular memory clinic?
Yes, that's one of the reasons that in this study we incorporated 8 different memory clinics, and the Alzheimer Center Amsterdam is one of them, but we also collected data in 7 other clinics that were more like peripheral local memory clinics. And in this study, although we included 115 patients, the sample wasn't big enough to statistically calculate differences between Alzheimer Center Amsterdam and the other memory clinics. But if I looked at the reasons stratified by memory clinic, I also didn't notice any trends. There seems to be a lot of variation in reasons for coming to the memory clinic across all clinics. So also in the peripheral memory clinics, patients have really specific questions that they would like to have addressed at the memory clinic.
Thanks, Leonie, for that explanation. Very important. And there's another question. Here it is now, just upvoted. And I think that one is for you, Francesca. And the question is whether, do you think that fear and stigma are kind of somehow related to each other?
Yeah, it's a brilliant question. Absolutely. I think fear perpetuates stigma. So oftentimes if we're afraid of something, it's that kind of don't want to deal with it, and it's an othering. So you don't want to be in that category. And a lot of people I've spoken to with a diagnosis talk about that, about the othering. And that is a stigma and a discrimination that I think is still there, especially for other types of dementia outside of Alzheimer's disease, because there's a bit more awareness and understanding of Alzheimer's, but other people, particularly with other diagnoses, feel very stigmatized. And I think it's a fear aspect that relates to, I'm afraid I don't want that to be me, so I don't want to think about that or engage with that. Yeah, absolutely.
Okay, Francesca, actually, I see from Leonie now on our chat that she also had a question for you. Would you like to make the question yourself, Leonie, to Francesca about the stigma and Alzheimer's?
Yeah, I was wondering, do you think because of the increasing awareness of dementia and Alzheimer's disease in the general public, does that also increase fear and avoidance, you think? Or do you expect other relations when there's more media attention, for example, in the upcoming years? Do we have to fear for more fear and avoidance? Or what do you see as relations?
Yeah, it's a brilliant question again. I think it operates on different levels. So there's the individual level of, say, a participant coming into a study or a clinic, and the fear that we deal with there. So making people more aware of, say, their results. And that's one area where that could increase the fear for people if they find out maybe they haven't performed as well as they thought. So there's that individual level that we have to manage that context and make sure that we're not sending people out of the room with a massive spike in their fear. And that's something I think about because I measure fear in people all the time. So I bring them in and I make them aware of fear. But then there's also the societal aspect of fear as a kind of a public health messaging, I guess. And I think fear looks like it's increasing a little bit, probably because people are becoming more aware, and probably because a lot of the stories that we hear about are quite negative and around end stage. We don't see as much representation of like all the brilliant work that our ambassadors are doing. Even in TV shows, it tends to be, when people with dementia are represented, it tends to be the person in the nursing home. And so if we keep seeing that side of the condition, people will be fearful. So I think we need much more representation of, yes, you can live well with dementia for a long time and you can still do all of these things. So it's a bit of it depends, I guess. Like, it's not, in terms of answering your question, do we think increasing the awareness would increase the fear? If we don't do it right, yeah, I think it would, but it's just a lot more work for us to do and context, because it will be individualized for people. Yeah.
Very interesting, Francesca. Actually, there's more about the fear and avoidance in the chat, and this was, Francesca, very interesting talk. Could it be that the fear avoidance is actually the first symptom of AD, and would that influence the intervention?
Yeah, again, an excellent question. It's yes, it's possible. So it could be that people are experiencing changes in their cognition, and their awareness about that is making them fearful. So that's difficult to measure. We will need longitudinal studies to try to determine the direction of that. It's a little bit like depression and dementia. So for a long time, we've been thinking about, is depression an early symptom or is it a risk factor? And I think fear, we can think about that in a similar way. It could be the case that some people are experiencing changes and then the fear comes, but for others, I think it could be a fear due to a family history with no objective changes, and then people shift their behavior. So yeah, it's complex relationship. Directionality, we don't know yet. Yeah.
Excellent. Thanks so much for that. I have a question for you, Kathrin, in relation to the exercise as well. A couple of questions. So one of the questions where you mentioned there was no any positive effect on cognition, but also the question is, were there any positive effects of exercise on other aspects, such as, for example, quality of life?
I only included trials which analyzed these three things, so I don't know something about quality of life, but that's a good question. I'm going to take that with me.
That's great. And there's a second question also related to the exercise, and excuse me, it was in relation to at which stage of dementia were the people involved in the exercise with BPSD problems, and whether you know which areas within BPSD were most beneficial.
Mostly they did not report the stage of dementia, but they provided the baseline MMSE, and that was mostly of a moderate stage. I know by heart that the intervention who found improvements in BPSD had an MMSE of around 19 as an inclusion criteria. So everything below would be excluded in that. And yeah, the parts of BPSD which were which had the greatest improvements, it's hard to say because they measured it with the NPI, and that measures all of the BPSD, so hallucination, agitation, and all of that.
Thank you for that, Kathrin. I think there's also one question for you. I think it's for your presentation, but I'm not too sure. Could you find some interesting results for certain subgroups, and do the studies reviewed report subgroup analysis? Okay, yeah. Thanks for that. That's a good question because some trials did report subgroup analysis, and the interesting thing is that there's an independency of the findings concerning sex, age, baseline MMSD, and also adherence to the intervention. So they performed subgroup analysis but didn't find any differences. Okay. Thanks a lot, Kathrin. I have a question for you, Kathrin. And it's, why do you screen titles and abstracts separately instead of simultaneously? And this is in brackets what I understand from the flow diagram. Yeah, that's absolutely true, and a very good question, because I was thinking about that too. And when I came to write this review, I just read about how to write something, and I got this publication on PubMed. I think it was from Martin, and the precision was higher when you're screening title and abstracts separately than together. That's why I decided to do it like that. Thanks a lot, Kathrin, for that clarification. Our audience was very, very much to detail. They were really concentrated following all the details. There's a question, Francesca, which is, I think, along the lines we have already addressed, and is how can fear and avoidance be tackled, and whether promoting awareness could help. And I don't know what you want to add. I know we have already talked about awareness and information and so on. I know whether you have any further thoughts.
Yeah, no, it's a great question. And I think it goes a little bit back to what Esme was saying. You know, I think a lot about even if we did show a very strong causal relationship between fear avoidance and risk, how do we then tackle that? And it's difficult to motivate people if you're trying to motivate them for the future, and you're trying to say to people in their 20s, you need to do this now so that when you're 60, you don't get dementia. That's very hard. So we need to think about practical solutions that apply to people's everyday life, I think. So I really agreed with what you were saying, Esme. And also to increase the awareness and the voice of people who are living with the condition. I think that's the only way that we'll really tackle the stigma aspect.
Yeah, absolutely. I was actually thinking when you were speaking, Francesca, about Leonie's speech also, and about how people sometimes didn't want to be there or were not sure why they were there, and how this might actually link back to fears and avoidance and things like that. So I thought it was really nice to have both kind of reflection. I don't know whether, Leonie, you have, what do you, I know you didn't ask about that in the interviews, but what would you be your impression on that?
Yeah, I think what we noticed, at least in the memory clinics, is that there's more variation now, I think, than in the past in terms of what people want to achieve or think that they can achieve at the memory clinic. And I, for example, also spoke yesterday with someone from Scotland, and I think in the Netherlands there is maybe already more awareness or more media attention for Alzheimer's disease and dementia, and that also causes people to come into the memory clinic much sooner and with more specific questions. So I think it's a changing field that we live in right now, and all the things that we can do in terms of biomedical approaches has also impacts what people want to achieve and what they think they can achieve. So I think communication about it in terms of like public communication, but also in the clinic or in context of trials is really important to make sure that people have the right expectations and that we tailor care to their needs instead of what we think that they need.
That's excellent. Actually, there's just a question coming from you, Leonie, as you were speaking, and they say, how often did physicians ask patients about the reason of their visit?
Yeah, that's a really good question. I think we noticed a lot of times that the physician actually starts with asking, well, tell me something about why are you here? And then patients and care partners explain their symptoms, but that's not actually what they want to achieve. So I think they are asking a good question, but not the right question for finding out the motives or the needs of patients and care partners. And we need to be more explicit in really asking, what do you hope to achieve? Or what would you like me to do for you? Or what do you hope that the memory clinic, like the diagnostic trajectory, will result in? Because otherwise that conversation won't be happening. So I think, and that's on initiative of the physician, I think, of course, we can ask patients and care partners to be more assertive, but I think it's also the job of the clinician to open the conversation up about that.
Absolutely right. And Francesca, I think the last question is for you. If you measure fear of worsening memory, could that be representative of etiologies presenting with different symptoms?
Say that again.
Yes, I'll come back. Sorry about that. If you, excuse me.
No, it's not you. It's the.
Yeah, it's a long question. If you measure fear of worsening memory,
Mm-hmm.
could that be representative of etiologies presenting with different symptoms? I can copy it in the chat for you if you want. I think I might be able. No.
Yeah, no, and I think I got it in the second one. Thank you.
Okay.
It's a really good question. I'm wondering what I think about it. Yes, I mean, it would be the short answer. Oh yeah, great. If you were to measure fear of worsening memory, would that be representative? Yeah, it's a possibility, and I think it goes back to the longitudinal aspect. So at the moment, the work that I'm doing is cross-sectional. We're measuring this one snippet in time. And so it's very difficult to answer questions like this. And that's what we need these longitudinal studies for. And I think over long periods of time where we have repeated measurements. So I think it could be, but I don't know the answer to that. Yes.
Thanks a lot, Francesca.
Thanks.
And I have to say, the more upvoting comments are very interesting session. Thank you to the speakers, really clear. Thank you so much to all of you. Great session, very interesting points. So I just have to actually join our audience in saying it's been a great pleasure to be sharing this very interesting session with you. I think you all have made really clear points and very, very well structured presentations. Thank you so much also for the very lively discussions and for sharing all your work and your opinions with us. And we are coming to the time that we need to close to go to the final plenary. So I wish you a very good afternoon. I hope you enjoy the very little that gets for the conference, and I hope to see you again next year in our conference. Thank you so much, everyone.